and welcome to the Alabama Public Health Training Network. The prevention and management of disease transmission is vital to overall health, making it imperative that healthcare workers protect themselves when caring for patients. Today, we will discuss epidemiology outbreaks from 2014, including a pediatric tuberculosis review. We will also discuss the detect, test, and report process. Thank you for joining us today for our program, Infectious Disease Review 2015. Today I have with me Dr. Mary McIntyre, who is State Epidemiologist and Assistant State Health Officer with the Bureau of Disease Control. I also have Jennifer O's, who is with us from the Infection Control Division of the Bureau of Communicable Diseases. And I'm Dr. Karen Landers, and today I'm going to be speaking on the topic of pediatric tuberculosis. If you have any questions about anything being discussed in our broadcast, please call or email during the session. The phone numbers and email addresses are on your screen now and will appear again later in the program. Also, the handouts, sign-in sheets, and evaluations are available online. You will need to register for this program in order to access those materials. Continuing education credits have been approved for nurses, social workers, and nurse practitioners, along with pharmacology, for today's program. In order to receive credit for this training, you must watch the entire program, then complete and return the sign-in sheet and evaluation. While content may continue to be relevant, CE credit will only be awarded for 1 year and will expire on March 31st, 2016. Again, I'm Dr. Karen Landers, Assistant State Health Officer, Medical Consultant for TB Control and Immunization Division. And along with me, as I have introduced previously, Dr. Mary McIntyre, Assistant State Health Officer for Disease Control and Prevention and State Epidemiologist, and Jennifer O's, Surveillance Nurse Supervisor. Welcome, everyone, and now we'll get started with our program. We're going to speak to the issue of pediatric tuberculosis, which is a special interest of mine as a pediatrician. Why is pediatric tuberculosis a major concern? Why are we worried about this in the 21st century? Well, tuberculosis is still with us, and pediatric tuberculosis is an indicator of the success of a tuberculosis control program. And early identification and treatment of infected children reduces the risk of progression to disease. In addition, with an increased number of foreign-born patients or first-generation patients of foreign-born parents, this is an important population that we can assess for risk factors for tuberculosis and have an opportunity to reduce or prevent this disease. If we look at the numbers in pediatric tuberculosis, one of the most compelling numbers I think that we can see is that infants and children birth through 4 years of age have a fairly high progression risk for disease. But if we look at that from a population of infants up to 12 months of age, those infected with tuberculosis can have a 40% risk of disease. And if we consider this, also we must realize that 25 to 35% of young children may develop extrapulmonary disease, such as TB meningitis. Again, looking at this by the numbers, it's a relatively small percentage of children that are infected that will develop this disease, but this is a devastating consequence of tuberculosis and one that we need to do all that we can to prevent. In addition, pulmonary represents most of the tuberculosis that we see in children, and this is certainly treatable, but at the same time, due to children being small with relatively small lung volumes, can prevent some significant issues such as hilar lymphadenopathy, compression of the bronchi, and some issues that we will talk about later on in the discussion. Lymphatic tuberculosis, such as scrofula, we don't see nearly as much in pediatrics as we used to, but this still can represent 12 to 15% of cases. Bone and joint being about 1%, and renal being about 1%. Early in my career as a pediatrician, I saw a child lose a kidney to tuberculosis. And this has compelled me through the years to identify children that are contacts of adult cases of tuberculosis very early, and to ensure that these children take preventive therapy to reduce the risk of such devastating consequences as this. This young child is now an adult. I still see this person periodically in my community, and I wish that we had his information earlier, had been able to be aware of him earlier than when he actually presented to one of our local physicians with renal tuberculosis. As we mentioned, other sites of infection can occur, such as skin, genitourinary, gastrointestinal, and upper respiratory. But for the most part, pediatric tuberculosis primarily presents as pulmonary, with the other sites I previously mentioned being the most common. Now let's talk about risk factors for pediatric tuberculosis. Well, again, one of the most important risk factors is exposure to an adult who has a high risk factor for tuberculosis. Again, a child born in a country that has a high risk of tuberculosis, or parents born in that country. For example, we may have children who were born in the United States, but their parents might have been born in Southeast Asia. They might have been born in Africa. They might have been born in Central or South America. And all of these countries have a higher risk of tuberculosis than we do in the United States. In addition, low-income people have more risk for tuberculosis, not because of their income, but because they have less access to medical care. And homeless patients, same, less access to medical care. Intravenous drug abusers, that's also a risk for tuberculosis, and we see tuberculosis in correctional as well as juvenile facilities. When we speak to the risk of progression, again, as I mentioned earlier, infection under 5 years of age. If you're under a year of age, as I said earlier, 40% risk to progression. Overall, 0 to 5 years of age, about 25%. In addition, after we go through what we pediatricians like to refer to as the golden age of childhood, we see an uptick of children that have been infected with tuberculosis at a younger age that might activate with tuberculosis during the adolescent young adult period. And we've seen some of this in the last couple of years in the Alabama Department of Public Health. We all know that due to HIV, that children that are infected with HIV have a higher risk of developing tuberculosis should they become infected with this germ. In addition, when a person is infected with tuberculosis, the highest risk period for them to actually develop disease is within a couple of years of the time that they convert their PPD or now convert their IGRA, their interferon gamma release assay. And finally, immunodeficiency. And we look at a special population when we're talking about immunodeficiency. We know that persons with diabetes have a compromised immune system. In addition, people with chronic renal disease. Malnutrition, we don't see that nearly as much in this country, but it does still happen. And as I mentioned earlier, immunodeficiency, let's speak to the issues of congenital immune deficiencies. Let's speak to the issues of problems with the immune system related to treatment with TNF-alpha inhibitors, such as JRA or Crohn's disease. This is very, very important, and in fact, one of the pediatric infectious disease physicians and I have been looking at ensuring that children that are placed on these drugs as a measure to treat their diseases, such as I mentioned earlier, Crohn's and JRA, that they are assessed for risk for tuberculosis and, if necessary, placed on preventive therapy, because we don't want someone developing tuberculosis if we can possibly prevent it. Now let's talk about the PPD for just a minute. Again, in my era, this was the test that we had to try to determine if a person had been infected with tuberculosis. But the PPD is not everything, and it is certainly not diagnostic, and we certainly can see people who have been exposed to tuberculosis and develop disease and may have a negative PPD. So it can be useful if it's positive, but we also have to remember that infants prior to at least 16 weeks of age can't mount an immune response. So we know that it may take up to 24 weeks for these children to convert their PPD. And some of you in the audience might say, well, why are you checking a baby, for tuberculosis? Well, we have infants born to mothers who have TB. We have that happen here in the state of Alabama. We have infants living in the house with someone who has tuberculosis, and the child may be under 16 weeks of age. So again, we place a PPD, but we don't really expect any results on that PPD unless the child is at least 16 weeks of age or up to 24 weeks of age. And in fact, I just recently reviewed some literature on this, and I'm tending to lean toward the age group of 6 months, because I believe that will give us the best opportunity to ensure whether or not that child's T-cell response is such that we can assess whether or not they have been infected with tuberculosis. Again, as I said, the PPD is old but not gold. In other words, it's not the gold standard. If we have a child that has exposure to tuberculosis and they have a negative PPD, that is not going to prevent us from starting preventive therapy on that child until at least 10 weeks after the contact with the initial case has been broken, because as this information will show you, between 10 and 40% of children who have actual tuberculosis disease do not have an initially reactive PPD. And this is thought to relate to the immune response of the child. And a lot of times after you've treated the child for a period of time, you can go back and do a PPD and it will be positive. Excuse me. So which children should receive a PPD or an IGRA? Again, we do use IGRA in children that are greater than 2 years of age. Well, if we have contact to known or suspected cases of tuberculosis, and also if we have children with abnormal radiographic findings and clinical histories that are suggestive of a high-risk group, we would certainly go ahead and, as part of the evaluation, do a PPD. In addition, according to the Red Book, immigrants or adoptees from certain countries, as I mentioned here in the slide, Asia, Middle East, Africa, Latin America, former Eastern Bloc, and Soviet countries. Again, these are all areas of the world that have a higher incidence of tuberculosis, so they should be screened for tuberculosis infection. Children with travel histories to countries with high-risk exposure should be screened. And let's mention PPD screening. Early in my career, children at 1 year of age were recommended to have PPDs routinely. And what we found is that that information was not very useful, and we were getting a lot of false positive PPDs. So we do not screen routinely for all children. We screen children that are in risk categories and only appropriately screen. But when we talk about risk categories, we have to remember, again, children that are immunosuppressed, children that are going to be on prolonged steroid therapy, which would be greater than 2 milligrams per kilogram of body weight for longer than 2 weeks, or children that are going to receive TNF-alpha antagonist. In addition, as I mentioned earlier, the TNF-alpha, we also want to remember other agents may be out there that may affect the immune system. Children with JRA, Crohn's disease, these are the children that we are concerned about. IGRAs. I want to just mention the interferon gamma release assay, which is becoming my favorite test in tuberculosis control. I really prefer the IGRA if a child is 2 years of age or older. Some of the foreign-born children that we see have received BCG in their country of origin, and that can interfere with our ability to interpret the PPD. So again, if a child is 2 years of age or older, the interferon gamma release assay can be used. Other reasons that I like the IGRA is it's a single test. It's one test. We can do that test initially. We don't have to have the child come back in a couple of days for a reading as we do with the PPD. And I do think the IGRA is more objective. Having done tuberculosis control myself for a number of years, I know that I am looking at a skin test, I'm rubbing my hands over it, I'm trying to feel for the induration, I'm trying not to be influenced whether or not there could be redness there. So again, I think the IGRA It's a more objective test. I want to show you a couple of x-rays here. These are actually children that I've treated in my career as a pediatrician. I like to say when it comes to x-rays and tuberculosis, I've got a million of them. Unfortunately, I do have a few more than I would like to have because TB is still a problem. This child was actually a foreign-born child, and this child came to us as the result of a contact tracing investigation. In other words, a person had been in this child's household who had tuberculosis. Fortunately, this child was asymptomatic. Now, it's interesting that these chest x-rays can look quite awful, and these children can still be asymptomatic, running around playing, actually not even have a cough. So I think it's interesting when you look at this x-ray to see the consolidation on the x-ray, which is fairly significant, and you can also appreciate the hyaluradenopathy. Hyaluradenopathy, because of the way tuberculosis is transmitted, of course we inhale the germ, it gets out into the lymph nodes, and what we can see first is hyaluradenopathy before we actually see consolidation. So this child has both. I'll show you another child here. This is an African American child, and I mentioned the child being Hispanic and the child being African American because these are children that might have more opportunity to contract this germ due to being in a situation where they have less access to health care or a lower socioeconomic group. So these are situations that we have an opportunity to work with populations and improve their access to health care. This child had an endobronchial granuloma, and this was a very, very significant finding. This child also was asymptomatic. He was 9 months of age, but a 2.7 centimeter round opacity in the hilum, and that's not very hard to see on this x-ray. Both of these children, I treated both these children at almost the same time, and that's why I paralleled their cases, because the commonality here was very striking. We had both children under 2 years of age. The first child was 19 months. The second child was 9 months. They were both asymptomatic. We actually picked them up very early. Now, I mentioned the Hispanic child. We picked that child up as a contact tracing. The African American child had been around a case of TB, but had not been identified to us. However, a person in this child's family happened to see one of our disease control people out in the community and asked them if they were working on some tuberculosis. Of course, we can't convey that information, but did say that I think there's someone that might have been around TB. And of course, we say, well, just let us go ahead and check the situation out. And this child, again, had tuberculosis. But they were identified within a very short period of time from the investigation with the index case. Actually, about 3 days, as I said, this person just approached one of our people and said, I think I know someone who's been around the person, and maybe the person didn't give you the information because sometimes people forget who they've been around. Both these children had gastric aspirates, which is only about 20% positive in most cases of tuberculosis, even with a grossly abnormal chest x-ray like both these children had. They were both HIV negative, and I'm happy to say, if you look at this information, that their lumbar punctures were negative, and that always makes me feel much better as a pediatrician. We started the children on therapy 1 for drugs. Both cases were sensitive to all drugs. These children were treated successfully, resolved without complication. This was several years ago. Both of these children are now in elementary school, and actually a couple of weeks ago I saw one of the children who came into my clinic and obviously does not remember this, but his mother remembers the incident very well, and he always reminds me of, you were my doctor when I was sick. So again, glad to know that he has done quite well. Let's talk about some pearls of management here. In children, directly observed therapy, and by that I mean our taking the medicine to the patient, giving the medicine to the patient, watching the patient swallow the medicine is an absolute must. Watching a child swallow the medicine is a little bit of a challenge sometimes, and we'll talk about giving children medication in a few minutes. But again, You know, these are not the tastiest drugs that are out there, and a lot of times children want to resist them. The thing I remember about that child that said I was his doctor when he was sick is we had so much trouble giving him his medicine. I actually had to go out to his house myself and work with the mother to get him to take the medicine. And he would run around the room while we were trying to give the medicine. But we got it in him, and he's okay now. Cultural competency plays a great role in our success in treatment. And again, I mentioned that this was a Hispanic child and then also an African American child. I think we have to be very sensitive to values that are in the community. And if we can have a person who has the knowledge about the culture and knowledge about the values and knowledge how we can reach the population, that can help us very, very greatly in having good results. I prepare the parents for the journey. You know, when we have a case diagnosed and they see me the first few times, I tell them, you know, you may like me now. By the time you get to the end of the therapy, you're never going to want to see me again. But, you know, that's just part of the journey. I prepare them that it will be a long journey because we're going to be treating these children hopefully 6 months, sometimes with different diseases, or different situations we may treat longer. And of course, if we're doing preventive therapy, it will be 9 months. So I do prepare the parents that this is not like treating an ear infection. It takes a little time. I mentioned being creative about medication. Again, chasing the child around the room is an interesting approach. I had a child that would only take the medicine if it was rolled in a peppermint patty, and as a result of that, the child did quite well with the treatment, but I think his dentist was less than happy with us. We certainly encourage good dental hygiene, but a peppermint patty every day may not be the best approach to treatment. But nevertheless, we do what we have to. Let's talk about standard therapy. With children, isoniazid, rifampin, PCA, and EMB, with special considerations for alternative regimens if we have a multi-drug resistant, and we've actually dealt with multi-drug resistant in children. Now, I had the opportunity, and it is a real opportunity, a couple of weeks ago to hear Dr. Jeffrey Stark from Baylor talk about tuberculosis. And Dr. Stark is considered to be one of the premier experts in pediatric pulmonology and tuberculosis in the United States. And he really continued to reassure me about the safety of tuberculosis medications. Just last week at night, I was speaking to a mother on the phone about her concerns regarding her child taking INH. So it's very important that even when we educate a parent and even when they sign the consent to give the medication to their child, that we continue to reinforce the safety of these drugs, and we also continue to reinforce that we're going to be monitoring for any side effects. That's why I like directly observed therapy. Well, INH is a bactericidal drug, which means it kills the germ. And the beauty of INH is it does prevent emerging resistance to other drugs. Rifampin also is a bactericidal drug and has the same activity of preventing emerging resistance. Now, EMB is a bacteriostatic drug at lower doses, but again plays an important role in preventing drug resistance. And that is one of the hallmarks of tuberculosis treatment, is preventing drug resistance. And of course, PCA, which was introduced several years ago, allows for us to have shorter courses of therapy. Now, I mentioned side effects and concerns. I'm going to talk about the side effects. These are extremely rare in children. Now, if you read studies on these drugs in children, and much of the literature is not literature from the United States because TB worldwide is much more of an issue than it is in this country. In fact, just recently, one of the pediatric infectious disease doctors at Children's and I had to access some pediatric literature on treatment of tuberculosis in a young infant from a journal in India. So again, people around the world have a lot of experience with this, and we tap into that experience. Isoniazid, again, is probably the most perfect drug in pediatrics, and I say that because I have heard Dr. Stark say it, and he, again, is considered to be a nationally renowned and world-renowned expert. Very rarely, and these, again, are considered to be side effects that you can see in adults, much more in children. And I've personally not had problems giving these medications to children, and I've given a lot of TB medicine through the years. Peripheral neuropathy, seizures and an overdose, hepatotoxicity, and I tell parents if the child is not over 35 years of age and not drinking alcohol, which again in a toddler is not a problem, but we have to consider in adolescents, hepatotoxicity is really, isoniazid-associated hepatotoxicity is really not an issue. B6 can prevent neuropathy. It's the only treatment for isoniazid-associated seizures, but it does not affect hepatotoxicity. And again, this drug in children is considered to be extremely safe, and we do monitor the children closely for symptoms. It is not necessary to do liver functions on children that are on these medications unless there is some other underlying situation, such as a child that might have hepatitis B or hepatitis C. Now, one thing I do throw in is certainly we are giving hepatitis vaccine in infancy now, and we're giving hepatitis A vaccine at 1 year of age. But when I pick up children that might not have had the opportunity to get hepatitis A vaccine, most of them have had hepatitis B because of it being a vaccine of early infancy, then I take the opportunity to protect the liver further by going ahead and giving my hepatitis A vaccine when I see the child if they have not taken their initial dose and then their second dose 6 months later. Now, let's talk for a minute about rifampin. Again, it activates oral contraceptives. Well, you know, when I started out in pediatrics a number of years ago, I did not appreciate this probably being an issue because I was more focused on very young children. Now, obviously, with teenagers, I have to be aware of this. Rifampin inactivates oral contraceptives. So if we're treating an adolescent girl, we have to be very, very cautious about making her aware of this and using other methods of contraception. There are many drug interactions with rifampin. Practically speaking, if we do not have a child that is on a lot of medication, then we don't have to be concerned about it. Rarely can have hepatotoxicity. And I warn the parents about the orange urine and the orange tears because, you know, having seen that, it's a little bit alarming if you're not aware that that can happen with the children. So I remind the parents over and over and over. Now the diaper, if it's a younger child, the diaper is going to have orange spots in it, and that's okay. And that when they cry, their tears are going to be orange, and they're going to spit orange, and just be aware of these things. And I don't think you can tell a parent that too often because, you know, they're getting a lot of information when you make a diagnosis, and they might forget some of these things. So you have to remind them again. Now PZA, again, practically speaking, in children, we don't have an issue with gout, but we do have to be aware that it does increase the uric acid. Rash and pruritus can occur. And actually, according to Dr. Stark, in the information and rare instances that he has seen any related elevation of the liver function, it's more likely to be associated with PZA. He presented a case, and for those of you who might want to look at this, it's actually on the Southeastern National Tuberculosis Institute's website in Lantana, Florida. Excuse me, it's not in Lantana anymore. I think they've moved to Gainesville. But nevertheless, the information in Dr. Stark's presentation is very, very useful. And there's an 8-part series. I think they've completed 5 parts on pediatric tuberculosis, and there are additional webinars being planned over the next few months, and these are archived on the SNTC website. EMB was a concern for me for a long time because initially we used only 3 drugs in as therapy 1 in most children, and so I was a little nervous about EMB. Having learned about red-green color blindness and optic neuritis, which is, you know, really a concern to me, I really had a an issue using it in children that were younger than 4 to 5 years of age. But there has been a significant amount of pediatric literature that has reassured me that this is a drug that has been used worldwide in children, and literature does not indicate that this is an issue that we have to be so concerned about that you would not use this drug. Now, initial ophthalmologic examination is still recommended, and follow-up for children that are on EMB. So overall, the risk of side effects in children is very low, 5% or less, and abdominal pain without elevation of LFTs. Again, we don't routinely screen LFTs. If we have a reason to screen or do LFTs for some other assessment, you can see about a 3% increase, but overall not considered to be a significant problem in pediatrics, and so we do not routinely do that. And I just received an article on that from one of the infectious disease doctors at Children's. So let's talk a little bit about follow-up with children with tuberculosis. If we have pulmonary disease, then we're going to do a chest x-ray depending on the clinical situation, 1 to 2 months after therapy. We had a very young child with tuberculosis a couple of years ago who had quite significant adenopathy and had some compromise with the nose pressing on the trachea. Now, this child was placed on steroids to reduce the size of those lymph nodes, and we did follow the chest x-ray a little more closely in that child, not because we expected the infiltrate to clear that quickly, because it takes a while, but rather to assess the size of those lymph nodes. And again, as clinically indicated, so we were more particular in that particular case. And then at closing of the case, you may still see some abnormality on the chest x-ray because the clinical improvement will be happening earlier than the improvement on the chest x-ray. And again, monitoring patients if they have severe disease or other conditions that may affect the LFTs. I mentioned earlier a person who might have hepatitis C or some other medications that might be taking that might affect the liver. So we have to be aware of the entire clinical picture with the child. Now, as I mentioned earlier, ophthalmologic monitoring with EMB. There are some experts that have indicated that it might not be necessary to do ophthalmologic monitoring for as long as we have done it, which again is the period of time that the child is on EMB. However, other experts are still indicating that ophthalmologic monitoring for optic neuritis should be done on a monthly basis while the child is on EMB. And that's what we are still doing. The infectious disease doctor that I work with at Children's and I feel more comfortable that we should continue to do this until there's further literature to indicate that we might change that recommendation. Now let's talk about corticosteroids. Well, I did mention earlier the child that I treated a couple of years ago that had significant lymphadenopathy. And this particular child, we did use steroids on this child for probably a couple of months because we really needed to reduce the size of those nodes. Corticosteroids are a standard of care and considered to be useful in tuberculous meningitis because it does decrease the inflammation. So it's pretty much a standard of care with that. How to give TB medication to children. Whenever I do this slide, how do I give TB medicine to children? With great difficulty, okay? But we get it down. And some kids, amazingly, will take their medication very readily. But we always have the challenges. And also you have to remember, this is not like an ear infection. We're not going to give the medicine for 10 days, and then it's all going to be over. Giving medication on a daily basis for a period of time, depending on when we determine that we need to go from daily to twice weekly. And that's not really part of my presentation, except to say that in children, there are standards about using daily medication and then twice weekly, which has been extrapolated from adult literature. But there is an article in Pediatrics in Review from 2010 that indicates that twice weekly medication in children is acceptable. I tend to go with daily with very young children for a longer period of time, maybe even 6 weeks to 2 months. I will switch to twice weekly in children after a couple of weeks or so in older children. A lot of that relates to how well they take the medication and giving directly observed therapy, because if a child has tuberculosis, they're getting directly observed therapy. And children that are contacts and high risk to cases of tuberculosis are going to get directly observed preventive therapy if they're under 5 years of age. We might, with older children, give the parents the medication for preventive therapy and have them give it if we can do phone call follow-up. My goal and my desire would be to give directly observed preventive therapy to all children, but depending on the staffing we have, we might not always be able to do that. So for a TB case, directly observed therapy. That child gets all the medication given by the health department, healthcare worker. In the older children, sometimes I will use the school nurse. Directly observed preventive therapy, we do that in children under 5 years of age, and depending on our staff resources, over 5 years of age, again, depending on how we can work that into the situation for patient care. It is very important if we can access the school nurses in some of the preventive therapy cases, because, I'm realistic about this. I'm a pediatrician. I had 2 children, and I can tell you that sometimes they didn't get all their medicine. Okay, so I'm going to admit that and say that we can miss a dose of medication in our children. And if we as nurses, pharmacists, and physicians can do this, then other parents can have the same challenges that we have. Plus, we also can have children that run around the room and spit medicine out. So it's very important to be vigilant with this, because we do not want to develop drug resistance in a child. That would be devastating. We've treated some drug resistance in children that have acquired it from a case, and we also do not want to prolong that therapy. We want to get that therapy done, get that child treated, and get out of that parent's situation so they can move on and do the things that they need to do. So back to how to give medication to children. I tell the parent when we start out, I want to give this medicine to your child. I want my staff to give this medicine to your child, because I know how important it is for the child to complete the medicine. And then I share my story, about my 2 children. Now, if I, as a doctor who takes care of children, can miss medication, then everybody can, because this is what I do every day, all day long. So I want to alleviate them of that burden and that responsibility. So we're going to give the medicine. And I tell parents, it's not that I don't trust you, but I know that missing medication can be devastating in a young child. It can be devastating in an adult, but in a young child, certainly we do not want to miss TB medicine. Now, have a friendly, positive, age-appropriate dose approach to the child. If you're dealing with a teenager, I'm not sure how friendly and positive we can be with any teenager, but, try to tailor it to that situation. Infants, sometimes not too much of an issue depending on the taste of the medication. We do like to compound medication, and I do take every advantage of working with my compounding pharmacist to put that medication in a form that is reasonably palatable to the child and the concentration is not so large. Example, liquid INH that is available through pharmaceutical manufacturers has a high concentration of sorbitol. And any of you that have ever encountered that, it's very, very likely when you give sorbitol to a young child, infant young child, they will start having diarrhea, and that does not make the parent happy. It doesn't make the child happy, but it really doesn't make the parent happy. So I pretty much don't use the liquid INH preparation that's commercially available. But with compounding pharmacists, they're able to get this into a form and a concentration, for example, 50 milligrams per ml. If you've got to give 50 milligrams of INH to a child, and again, that's a dose for a child that's between, 6-10 pounds or so. I mean, if you want to give that, if you have to give that child 5 milliliters, well, that's a lot of volume. So again, a 50 milligram per ml or as concentrated by that pharmacist. And we use our compounding pharmacists throughout the state. We have several resources, and it's very useful. Another thing that I like to do is grind the medication up and put it in a vehicle that the child will eat, a vehicle that the child will like. But I recognize that there can be challenges, and there will be challenges in giving the medication, but they can be resolved. And again, I mentioned the child that ate candy for that period of time. So something that we have to consider. I also tell parents that's another reason that we give the medicine, because that way the child doesn't like us. They don't have that problem, and they don't have that grudge against the child. Against the parent. So we try to be the ones to give the medication and be the bad people in talking about it. Now, when we're talking about the administration of drugs, as I said, the standard drugs are easier. If it's isoniazid, rifampin, PZA, and EMB, they're easier to give. They're the way these drugs are manufactured. You've got scored tablets. You can break them up. You can do the things you need to do. You can grind them. As I mentioned earlier, the sorbitol is not a good medication. It's not a good vehicle to use. Crushing and mixing medication, I mentioned suitable vehicles, and I have used just about all of these. In fact, I have used all of these. I have a friend who uses the spinach baby food, and I don't know where that particular child that they've given that to comes from. It must be a vegan child, because I don't know any children that would eat spinach baby food, but maybe there are some out there. I have great luck with applesauce. In fact, there have been some studies on using applesauce, and apparently good with absorption, chocolate whipped cream, pudding, the hazelnut spreads, juice, simple syrup. We had a child that we would make the medication in a very small snow cone type cup, and they would eat the medication out of a little snow cone cup, and it worked. So again, we did what we needed to do. So I want to close by just pointing you to the references that I have used in this. Again, these are readily available resources. These are available on the internet, and of course you do have those in front of you. And this information, I think, gives a much more in-depth view of what I have been able to do today. Again, pediatric tuberculosis is a disease that we would like to prevent. The way we can prevent it is by early identification of adult cases and the contacts to those cases, being vigilant about determining who those contacts are. And in addition to that, once these children are identified, if they are a contact and they have TB infection, making sure they take their preventive therapy and take it for the correct and prescribed period of time. Now, in terms of disease, I tell parents, we've got one shot to get this right, okay? So let's recognize we have to be in a partnership. Let's recognize we have to be compliant. Let's recognize that we have to do things in a way to ensure this child gets their medication. If we need to do things such as have a parent brought into the health department to give the child the medication, that we can do that. If we need to go out to the home, we can do that. We can involve our social services. Some of our patients have other issues and they might need to be connected up with other services in the community, such as services for additional health care, services such as housing. I mean, a myriad of social issues. But again, we've got one shot to get it right, and it's a disease that is very treatable, but it takes a village, if you will. It takes a team, and we have to ensure that all of us work together to reduce and prevent this deadly disease in children. Thank you very much for listening to my presentation today, and we will now take a 10-minute break. Thank you again for attending our presentation today. And after our break, we have a couple of questions from the studio audience about tuberculosis prior to continuing with Dr. McIntyre's presentation.
Yes, thank you, Dr. Landers. A couple of questions. First of all, if you could just explain a little bit about how you identify that a person has been exposed versus has disease.
Okay. All right. Basically, we do make a differentiation between infection and disease. Now, sometimes that's not a hard differentiation, but for the purposes of our discussion today, I'll try to make sure that I clarify that with the audience. Let's take an example. Okay, a child that has been exposed to a person with tuberculosis or with suspect tuberculosis, and we evaluate that child. Well, we know the child's been exposed. They've been in the household, or they've been in a household-like setting. We evaluate that child with a complete physical examination. We do either a PPD or an IGRA, again, remembering that we try to use IGRA if the child is 2 years of age or older. And then we obtain a chest x-ray. And that is, of course, if all the physical examination was completely normal, that child had no signs, symptoms, or other concerns about any extrapulmonary tuberculosis. Again, we would do either a PPD or an IGRA and a chest x-ray, PA and lateral. And I make sure with my colleagues to tell them it's very important in children to not just do a single view chest x-ray. We must do a lateral, because in children, the first sign that you may see of pulmonary tuberculosis is hilar adenopathy, and that's not always apparent on all PA projections. So it's exceedingly important that we do 2 views on a chest x-ray. Now, if that child has a positive PPD or IGRA and a negative chest x-ray, and that means no hilar adenopathy and no infiltrate, because if the child has hilar adenopathy, they're very early in disease. There's a little differentiation on how experts might recommend to treat that, but that's the subject of a different lecture. So going back to a positive IGRA or PPD and a negative chest x-ray, PA and lateral, we would consider that child to have tuberculosis infection. Okay, they have no disease. We would call them a latent tuberculosis infection, an LTBI. And that would be a child that would be recommended to take preventive therapy. Now, I give a word of caution here. We may have a child that's been a contact that has a negative PPD or IGRA and a negative chest x-ray, but we know that the exposure was significant, was intense, and that child is at risk. Then we would go ahead and treat that child for a period of 10 weeks after what we say contact has been broken. What that really means is the last time they were around that person was infectious. If they live in the household, we have to determine that based upon how the case progresses, how the person does on medication. But again, we would go ahead and treat that child with preventive therapy, again, directly observed preventive therapy until the time after the exposure to that case had lapsed, again, at least 10 weeks, or as I mentioned in very young infants, that time may be longer. And then we would repeat that PPD or IGRA as age appropriate. Now, if the test remains negative after 10 weeks from contact being broken, then we can discontinue the preventive therapy, and that child would not be considered an LTBI. So again, it's very important that we assess the child and determine that there is no disease. Now, in a very young child, we have to do other testing. Again, as I mentioned, a neonate or a very young infant, then a lumbar puncture is frequently recommended, and a test that we pediatricians feel like is extremely important because TB meningitis can be indolent. Okay?
Thank you. One other question too, Dr. Landers, is just a little bit about the direct observed therapy versus the non-direct. You talked about that a good bit. If you could just kind of summarize that,
right,
and how you manage that.
Okay, and that actually goes back a little bit to the question that you had. I talked a lot about infection in a child. Mm-hmm. So let me introduce some information about disease. As I mentioned earlier, a positive PPD and a negative chest x-ray, or a negative PPD and a negative chest x-ray in a child that has been exposed but we're waiting for that time period. Okay, those are either latent tuberculosis infection or a contact to a case, a suspect latent tuberculosis infection, if you will, and I make that term up myself, mm-hmm, because I say suspect, that's a little soft, but we won't know for that 10-week period of time, versus disease. Okay, we have a child who has either a positive or a negative PPD, either a positive or a negative IGRA, but they've been exposed to a case or they have other risk factors and they have an abnormal chest x-ray. Okay, they may be a case of tuberculosis, either a suspect case or a confirmed case. But again, as we mentioned, those two cases of tuberculosis that I treated several years ago, those were cases of TB disease. So that helps us now to talk about how we're going to treat them. I mentioned directly observed preventive therapy. You will hear us run around saying DOPT, DOPT all the time. Directly observed preventive therapy. What that means is that a child that has been infected with TB, but they do not have disease, in other words, they have the germ, but they don't have the disease, and I explain to the parents, they have the germ in their body, but it's asleep. That's the best way to help them understand it. And while it's asleep, we're going to kill it. Okay, so that helps them understand what we want to do. That particular child or those particular children would receive a single preventive drug for tuberculosis for a period of 9 months. And isoniazid is usually the drug that we use unless we have drug resistance in the case that that infected child has been exposed to. And it does present a significant problem if the child is exposed to a drug-resistant case. We can use rifampin as a preventive drug in children. We use isoniazid most of the time, again, because it's just the drug that we use if we don't have drug resistance. If we have drug resistance, that gets into a whole different topic and how we have to tailor that preventive therapy with both the drug as well as the time frame with that particular child. But for practical purposes, directly observed preventive therapy is a single drug, and we give it through the health department. And by that I mean either the child comes into the health department to take the medication, or we go out to the home or the school, or we engage the school nurse to give that preventive therapy. Because, you know, I've got an opportunity here. Directly observed preventive therapy is probably 95 plus percent effective in preventing that child from getting TB later in life. Now, that's data in very young children. The data in adults is probably not quite that high. Now, DOT, directly observed therapy. That's treatment of a child with tuberculosis. And again, as I told you earlier, as I mentioned earlier in the lecture, people with tuberculosis in Alabama get directly observed therapy. That's just the way it is. If you've got tuberculosis, we're going to treat you. Directly observed preventive therapy, if a child is under 5 years of age, we observe that medication being given to the child, or we give it ourselves. If it's, a nurse that, can give the medication. If not, if it's a DIS or a disease intervention specialist, they'll observe. But in talking about older children who would still be at risk and still need directly observed preventive therapy, we may not have the staff to go out and do daily treatment for the child. That's where we engage other partners, such as school nurses, because our goal is to get all of that preventive therapy in that child in the prescribed period of time. So with disease, it's mandatory. We're going to do this. With the, with the infection, children under 5, we're going to do all those children. Children 5 and up, we look at the situation. Many times the parents, with phone calls and reminders, they're comfortable giving the therapy, or, as I said, we can engage other partners. So, does that answer your question?
It does. Thank you very much.
Okay, thank you. Any other questions that I can answer for the audience?
I think that's all.
Okay.
Right.
If not, I'm very pleased to welcome my colleague, Dr. Mary McIntyre, who is going to continue our discussion with an infectious disease update. Dr. McIntyre?
Good afternoon. Hopefully I will be able to get this done within the time that I have, which is 45 minutes, really 40 now, to give enough time for Jennifer to continue with the information that she will provide. But I'm going to be actually talking specifically about the investigations, outbreaks, giving you some examples specifically of the what we consider some noteworthy outbreaks, and then ending with information about Ebola. I wanted to give you some idea as far as with the epi investigations and the numbers and how things have changed. Just for a 12-month period alone, there were 6,864 reports. From this 6,864 reports, there were 3,139 cases. I'll give you a little more information in just a minute or two to explain what all of that means. But what is not up here is since 2011, there has been a 400% increase in the number of outbreaks that have been reported and investigated. And so far in 2015 alone, there have been 93 outbreaks, with 41 of those outbreaks still under investigation, to give you an idea of what our staff are having to deal with. So when we look specifically at this may be difficult to see, but this looks at that 12-month period that we gave you information about. And we get what we call reports through lab results and also through people actually making calls and contacts. It can be consumers, it can be physicians. We actually have a web portal submission where we can get information in from reporters where they can let us know about whether specific things like outbreaks and other issues. The difference between investigations and cases is really looking at the information that we end up finding and determining. For a specific investigation to end up being a case, we have to have certain things met. Was the appropriate testing done? Did they do the right methodology required for us to count it as a case? Did they submit a specimen at all, and was it submitted appropriately? Was it packaged up, and was it actually a valid specimen that could be tested? All of those things we have to have in order to go from an investigation to a case. A lot of times, if you look right here at the information here, you'll see that there's a big difference in some of the numbers, where there are a lot of investigations and reports, but very few cases. And a lot of that is because we don't receive the clinical information, or there is not information that shows that from the standpoint of a case definition requirement, that there's any information to show us that it meets that definition. Sometimes the testing that was done, the wrong methodology was done. And when we follow up and try to get the corrected testing done, we never receive it. So there's no way it can be counted as a case. So when we look at outbreaks and clusters, this gives you an idea from 2011 to 2014 of specifically what we've been looking at over the past 4 years. And this is where we see that 400% increase with 32 total outbreaks in 2011. And you can see where we're looking at our numbers for 2014. And we're already at 95 or 93 for 2015. And it's probably more than that because we get reports every day. So the 93, I think, was as of Monday, and we're already at Wednesday. So we probably already have more than that that's already been reported because this is a daily thing. So what I want to do is talk specifically about some notable outbreaks for 2014. You'll see that there are 4 listed here. I'm only going to cover 2 of them. Specifically, I'm going to deal with one that's a Legionella outbreak, and then the other one that's Salmonella. Specifically, looking at what it actually requires to, for us to do or for staff to do when we have the reports and how sometimes these reports are received. So when we look specifically at the investigation, on Wednesday, June the 11th, there was a complaint that was received. Okay. And remember, I talked about that complaints can come in they can come from a person who was sick themselves. They can come from a physician that has noticed that they've seen an increase in people in the emergency room or in their providers' offices. They can come from employees that say, I need you to know about something that's going on. In this specific instance, there was a report that was received by the local environmental office that there were people that had been to a restaurant in Franklin County and that there were a lot of folks sick. Okay. So based on that complaint, the same day the environmental went out, and what they found out based on the information is that the event had occurred somewhere around June 4th or June 5th, and that people were experiencing symptoms of nausea, diarrhea, all of the things that we look at as far as gastroenteritis, as far as GI illness. And so in actually going out that very same day that the report was received, environmental identified within this restaurant that there were 7 critical violations. Food temperatures, the way food is stored. You shouldn't have the meats over vegetables. All of these are considered to be critical violations. Well, there wasn't just one critical violation. There were 7 critical violations. So the restaurant was actually scored, and it received a score of 53 as a result of the inspection that occurred. Now, that inspection score mandated immediate closure of the restaurant on June 12th. Any score of less than 60, warrants a restaurant being closed. I don't know how many of you have a habit of going in and looking at the restaurant score before you sit down to eat, but I'm one of those persons. I walk in and I look for it. I want to see exactly what the score is. And I have actually turned around and walked out of restaurants because of the score. And it definitely was nowhere near 60 or 70 or 80 that I would walk out. So my number is, if it's less than 85, I'm not going to sit down. Really, I prefer it to be in the 90s. But I kind of look around and try to see. But anything less than 85, I'm out the door. Okay? Immediately. So this particular restaurant score was less than 60. Did my thing die? Okay. So when we look at the particular with the investigation of with the violations, the restaurant was did it go back? Okay, hold on, y'all. It's going in the wrong direction, and I'm pushing the right way.
That's what it's doing there.
No, it's going in the wrong. Push. I'm going that way. All right, we're having technical difficulties. It's going in the wrong direction. Let's push the other direction and see if it'll go in the right direction. Okay, I think the battery is dead, y'all. No matter in which direction I push it, it backs up. I know. Okay, we're going for it. Sorry, y'all.
I don't know what it's doing there.
Can somebody give me a new battery or a new clicker? Or move it for me? If I say move, can you move it?
Yeah, we're back here. Keep going.
Okay. All right. And I'll just say next slide. Okay. So, as a result of this, we actually ended up with 56 individuals or people that were identified. And those out of that 56, 53 of them met the case definition. And remember what I said about having to actually have not just meeting the specific clinical definition, but also we look at whether or not certain testing and lab results were done and whether they were positive. So the people actually range from 4 to 68 years of age. And the majority of the cases were actually female. Why? I don't know. You know, it could be something to do about the restaurant or the event that was occurring to actually identify that. But I did not go into that detail here. So when we look at the next slide, please. So when we look at exactly when we're going in and we're looking specifically at foodborne outbreaks, one of the things that we talk about or that I learned early in coming to Epi was that Stuhl's rule. That's what they told me, Stuhl's rule, okay? And so it's extremely important to get stool specimens as soon as possible from anyone that reports illness. And in this particular incident, there were 30 stool specimens that were submitted to the state lab for testing. That's really unusual in some of the outbreaks that we have, since we sometimes have to battle and fight to get the outbreaks submitted. Next slide, please. It's going in the wrong direction again. Okay, right there, stop. We also got food samples collected by environmental, and in addition to that, they did swabs of the areas in order to see if there was actual the environmental surfaces, handles, any kind of like the stove, you know, all of those refrigerating things to submit. So they were all submitted. Next slide, please. So all 30 of the specimens yielded Salmonella enteritis. Okay, and one of the environmental swabs from the door handle also grew the same thing. So how do we know that the source is within the restaurant? Because the door handle with the environmental specimen that was submitted, there is something that we call a PFGE pattern, and that is actually looking at a pulse field gel electrophoresis. I don't know how many of you in school used to see these things where they would do like column chromatography, but it's a way of separating out the DNA. And I call it, it's like a DNA fingerprint. It's like when you're going in and you're doing genetic fingerprinting on somebody to try to see if the parent is related to the child. This actually would tell you based on the match, how well it matches, how likely it is. Now this is 100% match, and that's as good as we can get. Okay, so in this particular thing, we know that there was actually evidence on the cooler with the handle being positive as well. Next slide. This is the next investigation, and I'm moving from a foodborne outbreak investigation to a Legionella investigation. And so specifically, we're once again on September the 24th, this time we received, it really wasn't so much of a report, but looking at lab reports. In addition to the calls and providers reporting, we also get labs. And when those labs come in, they are reviewed. In this particular instance, it was identified that a routine laboratory, that one of the reports, that there appeared to be an association or connection to a particular plant because there was more than one. And so in looking at that, multiple employees at the plant reported being out of work sick. And this had been going on for a long time. So it wasn't something that had occurred in a couple of days, but this had been going on actually for months. Some of these people had been identified or diagnosed with pneumonia. And as a result of that, they were and I won't go into it, but some of them had actually, they were fearing that they would lose their jobs if they complained. Okay, so what is legionellosis? It's actually something that's really common. It's a bacteria. It's usually acquired or in the environment in warm water. Okay, it received its name from an American Legion convention that occurred in 1976. I'm sure that the bacteria existed before then, but that is actually when there were a lot of people that became ill. And I can remember this because I was in, at the time I can remember all of this commotion about all of these people becoming ill in association with, at that time, the air conditioning unit and all of that. And that's how I remember the Legionella. Okay, so there are actually two clinical presentations. You can have what people call Legionnaire's disease or Pontiac fever. Pontiac fever is a febrile illness, but people don't develop pneumonia with it. They can feel really bad, have symptoms really similar to having the flu, but they don't have the pneumonia on the chest x-ray. Legionnaire's disease is not just the symptoms and the fever, but pneumonia, and it can be severe. It really depends, a lot of it, on a person's immunity, whether they're immune compromised, comorbidities, people with respiratory illnesses already have a tendency to have more problems with it. So a lot of times we look for what we call the that canary in the coal mine, because usually the population where you see it cropping up in is a population that's usually already ill or already having problems. That was not the situation in this copper plant. These were people that were working every day. So when you look at that, you're looking at a situation where you would consider those people to be fairly healthy when it comes down to what's going on. So transmission is actually by breathing in the mist. You can't get it from one person to the other person. It's not person to person transmitted. We get a lot of people sometimes worried about that. They're afraid that if they go and they try to work as part of an investigation with a Legionella investigation, that they're going to pick it up from somebody that's sick. You cannot get it from another person. It has to be breathed in, and it has to come from usually one of these sources. And most commonly, one of the things I've become really particular in trying to walk around are those fountains, the ornamental fountains where you can actually get it. So when we look at this, we ended up with identifying the plant employees. The environmental survey was done of the facility and looking specifically at identifying the sources of where this particular infection came from. And we did clinical specimens. And while urine antigens were the initial tests that were identified, one of the things about the urine antigen testing is that it only picks up one serotype. And there can be exposures to sometimes multiple serotypes, and we may miss it if we depend on the urine antigen. So we always ask for sputums, respiratory specimens to be collected. And sometimes we have people say, well, we already did a urine. Even with doing the urine, it's always better to get that respiratory specimen submitted so we can make sure that we're not dealing with multiple serotypes. The state toxicologists and county environmental actually went in and did an environmental assessment of the water systems of the plant. And while I did not go to this plant and visit it, several other people did and reported that the systems were filthy. And so there was a lot of concern about the conditions that the people were in. And so when we're doing testing, it requires more than doing a swab like what's done of like the door handles and other stuff, but it requires what they call volume samples of water, at least a liter, to be collected, and for those swabs also to be taken and brought back to the state lab for testing. 36 employees were identified as being ill with respiratory symptoms and or GI symptoms, because you can have both. You can have one or the other. 35 employees were interviewed, and of those 35 interviewed, we actually received confirmation from lab testing on 17% of them. Remember what I said, that it's sometimes difficult to get people to submit specimens. We can ask, our staff can ask. People don't always submit specimens for testing. So we have to basically work with what we have. So from that, we had 4 that were positive by urine antigen, 1 that had a positive sputum culture, and 1 that was diagnosed by seroconversion, which means this, they look at an earlier specimen and then a later one and actually identify what happens as far as whether there's an increase in that titer to actually say that there's been seroconversion. So with this particular one, when we look at what was the finding, it was identified that the cooling towers were the problem. One of the things that we do is we don't just go in and say, oh, yes, you have a salmonella outbreak. That's what caused it. But also try to figure out how we can mitigate and make sure it doesn't occur again. So there are recommendations that always come from our staff, whether those recommendations are in the form of information related to proper handling of food, the proper temperature that the refrigerator needs to be at, foods that should not be placed next to each other or on top of each other. And in this specific circumstance, how often they need to do cleaning, what kind of cleaning needs to occur with the towers, that the plant has a plan in place to make sure that there is frequent testing and that this doesn't occur again, is one of the things that we did. Okay. So now I'm going to move into one of that has become my favorite subject and topic. Okay. And that is Ebola. It is one of the things that has not been in the news as often as it had been. Recently, on last week, we saw it again because there was someone that was a healthcare worker in Sierra Leone that had become infected, and it was brought in on last Thursday or Friday. And then they also brought in several other people to be monitored that had contact with this person. But Ebola is not a new infection. I've done several presentations just to community people, trying to explain to them is that this has been around for a long time. The reason why it became so much of hitting the news over the last year is because it is the largest outbreak, international outbreak with response in CDC's history. That means the number of people involved, not just that have become ill and that have died from this, but also the number of people that have had to respond to this is unprecedented. So when we look at exactly what the impact has been so far in the United States, we know that there are actually, diagnosis-wise, only 4 people were diagnosed actually in the U.S. Now, there are a total of 11 folks now that have been brought in, that have become infected, along with the ones that developed disease here. Okay, so out of this 4, 2 of these were imported, and another 2 were what we call locally acquired. And what that means is that they acquired the infection within the United States, and we all know that the only infection that's been acquired in the United States is from that index case that was in Dallas, and the 2 healthcare workers that became infected as a result of it. Okay, so when we look at the Ebola cases and the deaths, one of the things I left here was the February 21st numbers, because I wanted to let you have some idea how frequently those numbers changed. As of March the 11th, there's now a total of 24,544 total cases. So from February 21st to March 11th, 24,544. Total deaths as of March the 11th, 10,111. So people are still getting Ebola, and people are still dying from Ebola. Some of the reasons for that, there's been talk of the fact that some of the response has dwindled as far as the number of people that have been assisting and helping from multiple countries, and that may be contributing to some of the increase that's starting to occur again. So when we look specifically at the index patient, we all know that it was a person that came in. He came in actually to get married. came from West Africa, had symptoms that developed on September 24th, approximately 4 days after he arrived, or she, well, we all know. And so the person was not symptomatic when they arrived here, but there were multiple people within this apartment where this person stayed, children and adults, okay? The person ended up dying on October the 8th, and the person actually became infected with trying to do something good, and that was to help his neighbor, the neighbor's daughter, who was pregnant at the time, to try to get that person to the hospital. And that person ended up dying in that country, along with the infant, the baby. And this person came really, I guess, without explaining the extent of their exposure, which was something that was required. So when we look specifically at the Texas healthcare workers, I'm not going into any detail because you've seen them all over the news, but there were 2 of them. Care for the index person and was self-monitoring, presented to the hospital reporting a low-grade fever, was diagnosed on the 10th, ended up being admitted to the NIH Clinical Center. There are several of these centers spread throughout the U.S. We know about Emory being our closest location. But the other thing is now, because of the response that's occurred, there are a number of what they call Ebola treatment centers now throughout the United States, where a person can receive treatment for EVD and other serious infectious diseases. So the third was another health care worker that took care of this same patient. But this particular person ended up being taken to Emory and was released, got well. So the 2 healthcare workers with exposure within the United States actually survived Ebola and returned home. And we already know that there's continuing issues going on, and as a result of that, with the hospital that was involved and where the person was seen. The 4th case that we talk about is the New York medical aid worker, worked with Ebola patients in Guinea, was self-monitoring and reported fever, and actually also recovered on November the 11th. So during this outbreak, this number says 5, is now actually 6. So it tells you how this stuff changes. The 6th healthcare worker and 1 journalist brought into the United States for treatment after being infected. That 6th person was brought in on last week from Sierra Leone. I heard at one point earlier this week that they had become critical. I'm not sure of the status today because I haven't looked. So when we look at the healthcare workers that were actually brought from out of the country for treatment, one of those healthcare workers did die on November the 17th. And one of the things to keep in mind about this person is they had actually been symptomatic for days before they were brought into the U.S. It seems to be that the sooner that someone identifies the infection and the quicker that they get into treatment, the more likely they are to survive based on the information that we have so far to date. So when we look at transmission, and this is what I want to focus on, only a person who is infected and symptomatic can infect someone else. A person who has been exposed to the virus without any symptoms, if they're asymptomatic, which means they have none of the symptoms, they cannot give it to anyone else. You can't sit down at a table with them and talk to them and end up with the infection, okay? It requires direct contact. And I'm going to go into some details as far as what direct contact is. Dr. Landers just talked to you about tuberculosis. And TB is airborne and actually can be inhaled in closed spaces, and people can become infected without ever touching the person with TB. But you cannot do that with Ebola, okay? So how do we get the disease? Well, it's just like with a lot of things with infection control. Sharps, you can get injured from a contaminated needle or other sharp. Direct contact with a corpse, and some of the actual practices within these countries led to the spread of disease. because it's not uncommon for them to wash and bathe the body and multiple people to do that after they die. And they actually, a lot of times, will put the person back within the home, within that hut or wherever they are living, and they will keep them there for some time. It's like letting everyone grieve. Part of that practice is to grieve for the person that's died, and that's for days, you know, so they don't quickly take and put them in the ground after they're deceased. So that's some of the those practices led to the exposures. Indirect contact with an EBD infected patient's blood or body fluids. Soiled linens, taking them up, picking them up without having proper PPE on, use utensils, a number of these things. And one of the other things we have to remember is that in West Africa, it's not uncommon for a lot of people in some of the small villages to have to actually go out and hunt in the bush and get certain animals to eat. That's called bush meat. And that can include bats. You know, I was surprised, but it's not uncommon for them to actually stretch them out and to prepare them to actually eat. And that's for another source of the infection. We've had people now that's been concerned about pets, dogs and cats. We do have within our protocol a process that addresses and asks the question whether or not a person has a dog or a cat within the home when we're doing monitoring. And we do monitor people. I'm going to give you some idea on the numbers at the end. But what we actually ask people to do is separate their pets when they're under monitoring, so we don't have to worry about having to figure out what to do with them if they become infected. And when I talk about becoming, okay, I'm gonna miss it. When I talk about becoming infected, it's not the dogs or the cat, but the person. And so that's what we actually look at. I almost made it. So when we look at actually monitoring individuals, I want to give you some idea. So far, and this is from October the 11th, 2014 to January 31st, 2014. There have been 7,587 people who have arrived from West Africa that have, from the affected countries that have been screened on entering the United States. 7,000 plus. Of that 7,543, only 7.2% of them have had to be referred to CDC for on-site screening at the airport. Of that 543, only 12 of them were sent for additional evaluation, which means they were sent to a hospital to actually be evaluated. None of those had Ebola. Okay? So this gives me some idea of how hard it is to actually become infected with Ebola. Okay? Now for our numbers. As of March the 16th, and our numbers can change too because we do get reports from those entry sites, the 6 airports, and we get them from the CDC telling us the actual from quarantine that we have somebody that's headed to Alabama. And we monitor those folks, which means that we follow up with them on a daily basis for 21 days based on when they actually left the affected country. We've had a cumulative total of 44. And what this means is monitoring events. We've had a couple of people that have been monitored more than once. I know of at least one person who is a U.S. citizen who has been monitored 3 times because they work in West Africa, but they live in Alabama. And this person has had no problems, no symptoms, and they've been low risk, which means that they've actually had no direct contact with a person that's infected. We have currently 2 people that we're doing active monitoring on. We've had none of these people that have had any issues or problems at all. Okay? We've only, from the people we've had, we've only ended up testing one person, and it really wasn't because we thought they had EVD, but there was CDC. There are also other hemorrhagic fever viruses, and we just wanted to be sure, and that test was negative. So this gives you basically the information related to what we've talked about, and that EVD, or Ebola virus disease, while some of the media attention has been reduced, we still do receive calls, and we get calls from people who are still traveling internationally that may not have been to West Africa, but because they were in a restaurant or they sat on a plane beside someone that was from West Africa, believe they have Ebola. Remember what I said, you cannot get Ebola from someone that's not symptomatic. And you can believe that we will know if we have someone that's entering the country that is positive with EVD, because we do receive reports and the media is on it, so that we know that. We are continuing to do our monitoring and the process. We actually have a webinar on tomorrow just for our communicable disease folks that we're going to actually train and talk to them a little bit more about what it means and why we need everybody to be aware of how transmission occurs and how we can prevent and control infection. So there's a whole list of references here, and I'm going to turn it over to Jennifer.
Good afternoon. My name is Jennifer Owes. I'm the Surveillance Nurse Supervisor for the Epidemiology Division at the Alabama Department of Public Health. I've been asked to give a brief overview of our Detect, Test, and Report campaign. Our mission here in epidemiology is to protect the residents of Alabama and prevent illness by monitoring and investigating infectious, zoonotic, and environmental diseases, conditions, and exposures. Examples of each are provided here on the screen. An example of an infectious disease or condition would be salmonella, influenza, and hepatitis. Examples of zoonotic diseases and conditions include rabies, Rocky Mountain spotted fever, and West Nile fever. Examples of environmental diseases and conditions would include Legionnaire's disease, which Dr. McIntyre spoke about, and other chemical and toxin exposures. Our Detect, Test, and Report is they're acronyms for our Notifiable Disease and Condition Awareness Campaign. This campaign was created to educate reporters on testing and reporting diseases and conditions. It also provides education of the rules regarding and the appropriate time frames for reporting. Each of these areas has an individual web page that you can find on our ADPH web page, and there's information and pages dedicated to each of the different portions of the campaign, the Detect, Test, and Report. On those pages, you can find information that will give you the correct types of testing that we need in order for it to be considered a case. It gives you information on time frames and also on the individual diseases and conditions that we're interested in. The purpose of reporting is to prevent the further spread of diseases. You also provide education for patients, community members, and providers, and it can provide disease confirmation as well. Reporting notifiable diseases is required by law. The Code of Alabama, Section 22-11A-1, details who must report, the information that must be provided, and it also specifies the time frame in which the report must be provided to ADPH. The ADPH Administrative Code authorizes and requires reporting. It also states that ADPH is exempt from HIPAA privacy rules. The privacy rule expressly permits disclosure without individual authorization to public health authorities. We're authorized here at ADPH by law to collect and receive the information for the purposes of preventing or controlling disease, injury, or disability, including but not limited to the public health surveillance investigations and intervention. There are 9 mandatory reporters. Those reporters are listed here on the screen. They're physicians, dentists, nurses, medical examiners, hospital administrators, nursing home administrators, laboratory directors, school principals, and child care center / Head Start directors. Of these reporters, they may delegate the duty of reporting to another staff member. However, these are the specific reporters that the disease rule mandates have to report. All reporters have an equal responsibility for reporting diseases and conditions. Laboratories are not solely responsible for reporting all diseases that they result. In other words, we do not want you to assume that a laboratory or another mandated reporter has already reported the disease or condition. Everybody is expected to report, and we do expect and receive multiple reports of each instance. That's expected, and we do receive them on a daily basis. When reporting, there are minimum data elements that the code also specifies and requires. Those elements are listed here on the screen. We ask for the name of the disease or health condition, the patient's name, patient's date of birth, gender, address, phone number, the date of onset, date of lab result, and/or the date of diagnosis, in addition to the reporter's name and the reporter's phone number. Well, let me back up to this slide. I wanted to reiterate that reporting without the proper data elements does not eliminate or alleviate your duty to report. It doesn't. If you report it and you don't give us the minimum data elements, then you still have the liability of not reporting. Without the sufficient information, we're unable to investigate and therefore unable to accurately assess the disease burden. We have different categories of diseases and conditions. The first category that I'm going to speak to is the immediate, extremely urgent category. They're listed here on your screen. We ask that these conditions be reported within 4 hours of a presumptive diagnosis. We don't want you to wait until you have an actual confirmed laboratory confirmation for you to report these conditions and diseases. We need to know as soon as you think that this is a problem. You notice here that botulism is starred on the slide. Botulism is one of the diseases that has to have additional information. We request additional information here at Public Health in order for us to give permission for the testing to occur. There's also an immediate urgent category, and in this category, again, the conditions are listed here on the screen. These are some of your more common foodborne organisms that can be ingested through food or environmental exposures. Any of these conditions under the urgent category could pose, under the urgent or the extremely urgent, can pose extreme public health threats, and we here at Public Health need to know and be alerted of the potential threat as early as possible. So both of these categories ask that you report presumptive diagnosis. And it's okay if you report the presumptive diagnosis and you're incorrect or the lab findings does not support that. That we'd rather know on a presumption than not know in time to help the public and alleviate the threat. If you notice here on this slide, there are some different diseases and conditions that have been underlined in red. In our most recent update to our notifiable disease rule, which occurred December 31st of 2014, there were some changes. There were some things that were, some conditions that were moved up to a more urgent time frame of reporting. There were a couple things that were removed from the list, and they also, we also asked for, with reporting of hepatitis, that those reports include an ALT. That's the liver enzyme test that if it has been resulted, we ask that you send that in addition to the positive report. There, you'll also find here on this slide, on the bottom right, outbreaks of any kind in cases of public health importance. I think those go without saying why we need to know about them in such an urgent manner. But I do have them listed here, and we need to know about them within 24 hours because the timeliness of the reporting can help with helping to go, it goes back to our public health mission of protecting the citizens of Alabama. How to report the individual diseases and conditions. The time frame for reporting of the two that I've already talked about, for the extremely immediate, extremely urgent conditions, they must be reported within 4 hours of diagnosis. This report must be made via telephone. There's a number provided on the screen. This number is also provided on our ADPH webpage, and they, as I said, they must be called in. We don't receive them by fax or email or any other method other than a direct speaking to someone directly over the telephone. For the immediate urgent conditions, we ask that those be reported within 24 hours of diagnosis. That's found on the second half of this slide. We ask that they're reported within 24 hours, and you can use either the online report card or our secure fax or email. This applies unless you're reporting on behalf of a laboratory. If you're reporting on behalf of a laboratory, you must report using our secure fax or email. You no longer can use the online report card as a means of reporting. For questions regarding this requirement, you may contact the Epidemiology Division of ADPH. Here you see a list of our standard notifications. These diseases and conditions listed on this slide were reportable within 7 days prior to our most recent update of the notifiable disease rule. The diagnoses that fall in this category should be reported within 5 days of diagnosis using our online report card. Again, not to pick on the laboratories, but the online report card is no longer an option for your reporting. You must report using an electronic method of our email or our secure fax. And if you look at the underlined conditions on this slide, you'll notice that, again, hepatitis, we only want the acute reporting of hepatitis B and C, and we ask that you include an ALT if it has been resulted on the patients. How to report those 5 days, the standard notifications, the ones that you can report within 5 days of diagnosis. Online report card, except for laboratories. You can call them in via the 800 number, or you can use the secure fax or the ADPH email address that's found on the screen. All these methods are listed on our ADPH webpage and can be accessed via adph.state.al.us/EPI for the Epidemiology Division. I have references provided here on the screen. Again, I'll refer you back to the ADPH webpage for any additional information. And this completes my presentation. I'm going to turn it back over to Dr. Landers, and we'll entertain some questions from the field.
Thank you very much, Dr. McIntyre and Jennifer, for very informative presentations. This concludes our didactic portion. If there are questions from the audience, we'll take those now.
I have one question related to just reporting and everything. And Dr. Mack, you talked about the salmonella outbreak and then the Legionnaire disease, and then now you've talked about, Jennifer, some more specific kinds of things, and those were on those lists. But I'm thinking in terms of our folks who work more in the community rather than the clinics. If they, they may not be getting that report directly, that the lab is positive, or even that real suspect, like in an ER or a doctor's office, of the symptoms. But if they're suspect of something, is that something as well that they should call in? And I'm assuming that it was the workers, I think you said, in one of those cases.
I mean, we receive reports we get reports sometimes from reporters.
Okay.
They're calling because they've heard of an outbreak, and sometimes they hear about the outbreak before we do, which means that we then provide that information to someone to actually review or to call and confirm. And often we do find out that there is an outbreak in the community that we're not aware of because we haven't received a call from anyone. We often receive calls from people who are family members, and they'll call and they'll say, I had an event on such and such a day, and I've had several calls from some people that say that they've had these symptoms. And then that initiates the investigation, which basically we have staff that make calls within those areas to try to basically vet it to see if there are actually issues and problems. So a lot of what we receive is not always from other health department folks, and in fact the majority of the time is coming from people from the outside or in the community, and sometimes from some of our health department folks that say, I'm aware of a church and I went to the event at this church, and I've heard that there have been a lot of people that have been sick and been hospitalized. So if you're aware of something, and this is the thing about everybody not thinking that somebody else has already reported, go ahead and pick up the phone and call Epi and let us know, because we'll tell you if we, know we haven't heard anything about it, and we'll send it up, and then people will at least look into it to see whether or not there's an issue. But a lot of the stuff we find out about is from people calling. I wanted to mention a little bit about the public health significance thing, that it can be a single case, or it may be several cases that people are seeing that they don't believe is something that they've seen before, or the presentation or clinical presentation may have changed. We sometimes get a single doctor that'll call and say, you know what, I've had a couple of patients with something that looks like, a disease, hand, foot, and mouth that I've seen in the past, but I'm seeing in older children. I've heard that it's been occurring in some adults. And we think something's going on. We've taken that information, and actually that led to the early identification that for Alabama being the state that found out that we had an outbreak of Coxsackie VA6, the first outbreak identified within the United States, that actually they could put a test result with it and say that this had occurred because a physician said, I think I'm seeing something different. And when it ended up, it was a presentation of a specific virus that had been seen in like China, Japan, and some other countries, but had never been identified as part of an outbreak in the United States. And that's because of a provider picking up the phone and saying, I don't know what this is, but it's different from what I normally see.
Well, thank you. Yes, I can see that application very easily for our home health staff and our other community staff who are working in those roles, because they're a little more involved in the community and what's going on, and perhaps even with the local physicians. Thank you very much. Thank you.
Are there any other questions from the audience?
No, not that I'm aware of them.
If not, thank you very much for attending our presentation today. We hope that you found it informative. Please follow the instructions that you've been given in order to receive continuing education credit, and this information will be archived on the Alabama Department of Public Health Training website.